From Louisiana.
I rise today to address a very important issue as regards to the health care of our poorest Americans and discuss my plan, the Medicaid Accountability and Care Act, or the MAC Act, and which is also included in my Obamacare replacement plan, which would address the failings of our current Medicaid system. My colleague from Washington just extolled the virtues of Obamacare, and Medicaid is clearly, as she pointed out, a major part of the Obamacare kind of response, and so it's apropos that I would follow. Let me first tell you my perspective. I'm a physician, and I've been working in a hospital for the uninsured for 25 to 30 years until they blew it up. I saw prisoners, the uninsured, and Medicaid patients. Now you might say, wait a second, Medicaid, it's insurance. Why would somebody with Medicaid insurance be seen at a hospital for the uninsured? It's because in my state, like in most others, Medicaid pays beneath the physician's cost of seeing a patient. It is, to paraphrase St. Paul, the illusion of coverage without the power of access. I'll point out that the week that Obamacare passed, there was an article in the New York Times written by Robert Pear, a very respected journalist, tracking a Medicaid patient in Michigan. And the physician, the oncologist seeing her, had so many Medicaid patients, the oncologist was going bankrupt because she could not afford to pay her bills. So she had to discharge the Medicaid patients from her practice. I followed up just to find out what would happen, and 2 weeks after being discharged from this oncologist practice, the patient died. Now, this is Medicaid, which is so critical to the purported success of Obamacare. Now, is it that we're not spending enough money? That maybe if we just spent a little bit more on Medicaid, it would all be better? A study out of MIT found that 60%, let me stop. Oregon did an expansion of Medicaid, the state of Oregon. And so researchers from MIT and elsewhere went and studied it. Now, this study found that 60% of the dollars used for the Oregon Medicaid expansion went to institutions, not for patients. As little as, let's say, 20 to 40%, but as little as 20% of the money that was put towards the Medicaid program actually was a benefit for the patient. Let me repeat this. 60%, as much as 60% went to benefit institutions, not patients. And they also found that patients on Medicaid did not have improved outcomes. Think about this. We're giving everybody all this coverage. It's supposedly wonderful. And yet when they went back a year later and 2 and 3 years later and looked at the patients covered on Medicaid versus those not, those who continue to be uninsured, there were no better outcomes, no better health outcomes among those who are on Medicaid. Now, if we can't agree that this is a program to reform, it's going to be hard to agree on anything. Now, let's talk a little bit for those who are not familiar with Medicaid. Medicaid is a federal-state program. The federal government provides a certain percent, different percent for each state, but the state actually administers the program. So in some states, the federal government pays 50% of the cost. It can go up as much as 75% of the cost. So in Mississippi, they put up $25, they get $75. In a state like New York, they would put up $50 and get back $50, so it's a 1-to-1. Now, this open-ended financing structure is based solely on how much the state spends. I'll agree with my colleague from Washington State. We should not reward states that spend incontinently. We should not reward states that just spend. But under Medicaid, the state is rewarded. The more it spends, the more it draws down from the federal government. I always smile when people speak about the economic development of Medicaid expansion. Medicaid expansion is not about economic development. It should be about taking care of patients. But I understand that perspective because they pull down at least $1 for every dollar the state spends. Sometimes sometimes it's a 75% ratio. And under the Obamacare Medicaid expansion, states have been drawing down 100% of what they spend. Now, if the state's going to draw down 100% of what it spends on the Medicaid expansion population, surprise, surprise, they're actually spending at a higher rate on the expansion population than on those Medicaid patients for which the state actually has to cover part of the cost. Now, the federal government has very little ability to weed out the corruption of the inefficient programs, again, this matching incentive disincentivizes states from looking for ways to be more efficient. But still, states have to balance their budget every year. And Medicaid is either the second largest or largest budget item in every state. So even though the federal government's paying 50 to 75% of the traditional Medicaid population and 100% of the expansion population, the state taxpayer is still on the hook for a lot. On average, states spend 17 cents of every state dollar on Medicaid. My state of Louisiana has the highest percent. 19% of our budget goes to Medicaid. The percent steadily increasing, nearly doubling since 2000. And sooner or later, even though the federal government covers the majority of the cost, the budget crunch gets more difficult because the rate of Medicaid spending is climbing faster than the state tax base. Now, because of all the federal requirements on what a state can change in the Medicaid programs, in order to come up with the state match, states have two options. They can pay providers less, or they can cut other programs like education and move the money to the Medicaid program. First, paying physicians less brings us back to the situation Robert Pear described in his New York Times article, where the oncologist was going bankrupt because she could not afford to see more Medicaid patients. But let's speak a little bit about education. In 1963, state government spent, I'm just going to use my hands, about that much for education, and that much, 1964-65 when Medicaid started, about that much for Medicaid. In 2009, for the first time ever, on average, states spent more on Medicaid than on education, and now the percent on Medicaid continues to climb, if you will, cannibalizing the state dollars that could be used to support higher education, primary and secondary education. Let's look at the effect of the Obamacare Medicaid expansion. Let's look at Kentucky, not my own state, but Kentucky, a state which has been at this for a little bit longer. The previous governor, Governor Beshear, implemented the Obamacare Medicaid expansion, just kind of traditional Medicaid, and expanded. And again, my colleague from Washington State was kind of, again, extolling how much Obamacare has lowered cost. Well, when Kentucky originally implemented, they expected the long-term cost of the Medicaid expansion to be only a 4% increase in their current state spending on Medicaid. After only 1 year of the expansion, updated projections show that the expansion cost the federal government more than $500 million more than Governor Beshear had projected for 2014, and this will double in the coming years, meaning that the Medicaid expansion will cost $1 billion more per year than expected. Again, this was the projected cost. This is the actual cost. Now, if this is saving money, oh my gosh, let's not, what would happen if we actually lost money? I mean, by anybody's calculation, this is losing money. And this has been the situation across the country. States that have expanded Medicaid, it has turned out far more expensive for the federal taxpayer than originally anticipated. Now, again, it just isn't a federal program. Like many other states across the nation, Kentucky is facing serious fiscal issues. They don't have $1 billion lying around. And on its current path, Kentucky's own projections suggest that the state will start losing $45 million in perpetuity beginning in 2021. This is a 10% increase. So the federal government's putting up most, but Kentucky itself will have to put up an extra $45 million per year. Now, also, given that the federal taxpayer, you and I, us, the people watching on TV and in the gallery, given that we, the federal taxpayer, put up 90% of Kentucky's cost, but every state's cost, we just happen to be speaking about Kentucky, 90% of the cost in perpetuity, as this cost grows, taxpayers are on the hook for 90% of it. Such a deal. Now, it doesn't have to be this way. Let me compliment Indiana. In Indiana, Vice President-elect Mike Pence, when he was governor, rather than adopting kind of Obamacare as this is due traditional Medicaid and watch this cost explosion, took an innovative approach and created the Healthy Indiana Plan, or HIP, as an alternative to simply doling out the dollars. The plan gave each beneficiary a high-deductible plan in combination with the health savings account. It was capitated, so again, my colleague from Washington who just spoke kind of criticized these capitated plans, which means there's a set amount, and the person is, if you will, engaged in managing her dollars. The state would put up a certain amount on a sliding scale based upon the Hoosier who enrolled their income. The plan empowered low-income enrollees to become better consumers of health care. Hoosiers who participated, for those not from Indiana, I've learned, you don't say Indianians, you say Hoosiers. So, Hoosiers who participated changed behaviors. They used 40% less charity care than traditional Medicaid patients. 70% contributed to their own HSA. Once they started contributing, virtually all continue to do so regularly. And that is despite 83% of those participants in the Healthy Indiana plan earning less than the federal poverty level. Those Healthy Indiana plan patients also saw clear improvements in care over traditional Medicaid. They decreased their emergency room utilization by 40% relative to Medicaid's average, had thousands more physicians chose to take Medicaid patients. Remember I discussed at the beginning how physicians often can't see Medicaid patients. It pays them below their cost of seeing care. In Indiana, thousands more chose to take Medicaid patients, improving access to quality care. Clearly, the Healthy Indiana plan was able to work for Indiana patients. This is the sort of quality innovation that states can devise if we give them the power. Now, revising the current funding structure would also encourage states to follow Indiana's example and develop innovative Medicaid programs to increase the efficiency in which the program spends money. Again, that's federal taxpayer money. That's our money. Anybody watching right now, it's our money. We want to encourage states to be efficient as how they spend this. There should be greater flexibility to design the Medicaid program to better meet the need of state residents. States would be given the latitude and freedom to develop various coverage options and specialized delivery systems for different Medicaid patient populations. This is why I developed the Medicaid Accountability and Care Act, which we call the MAC Act. It reforms the flawed financing of Medicaid by giving each state a set amount according to how many people each state has enrolled in the different categories that each state's Medicaid program treats. That's a mouthful, but it's basically exactly like the Federal Employees Health Benefit Program, or like any employer who goes to an insurance company and says, I'm going to give you a set amount of money per employee who enrolls in your plan. For that matter, it's like Medicaid managed care, where the state will go to a managed care company and give the managed care company a set amount per enrollee in that plan. Now, I hear people say, oh my gosh, it's a set amount. That's all we do in healthcare, except in Medicaid, where we reward inefficient spending. So if it's good enough for the state to do it to the Medicaid managed care program, why isn't it good enough for the federal taxpayer to do it to the state? I'm not quite sure I understand the critics of this approach. But again, under the Medicaid Accountability and Care Act, or the MAC Act, each state would tell the federal government how many beneficiaries it has in different categories of Medicaid, and the federal government would give each state the amount of money appropriate for that number of enrollees in each category. The advantage of this, it is a set amount. It allows the federal government to do that which it does not do now, which is to say to the state government, if you recover fraud, you can keep that money. Now, let's go back. Under the current situation, the federal taxpayer pays 50 to 75% of a state's Medicaid cost. If there is fraud, and there's lots of fraud in Medicaid, and the state government recovers it, it has to give back to the federal taxpayer whatever the percent was the federal government put up. So if the state goes out and recovers $1 million, spends money on the attorneys, spends money on the investigation, all in the court case, it recovers $1 million. It has to give $500,000 to $750 million back to the federal taxpayer. It's responsible for the prosecution, the investigation, but it gives most of the money back to the feds. So the states don't investigate. I mean, it's a disincentive to go after fraud. Under the MAC Act, if the state goes out and gets $1 million worth of fraud, the state keeps the money. That's good for the state. It encourages the state to root out that fraud and to keep the money and to make sure that fly-by-night scam artists never get to become Medicaid providers in the first place. The MAC Act's reforms will result in improved health care for Medicaid patients. I'm going to go back to where I started. I'm a physician who worked in a hospital for the uninsured and Medicaid patients. These are my patients. And if this proposal was not about improving patient care, I would not advance it. But recall that Oregon, with their Medicaid program, upon review by MIT, found no improvement in patient outcomes. Then let's go to Indiana, which actually set up health savings accounts, engaged the patient in managing their own health. There, we do see better outcomes. We should all be about patients having better outcomes. Along the way, we do other things, such as equalizing the amount of money the federal government gives to each state per beneficiary. Again, my colleague from Washington State kind of pointed out that folks in Washington get less money from the federal government than do other states. I would attempt to equalize that with the MAC Act. And so let me finish. The American people have been voting against Obamacare for the last 8 years. Whatever its proponents may say, the American people have found it wanting. One aspect of which it has been wanting is Medicaid. We have a proposal before us based upon my experience treating patients in a hospital for the uninsured and for Medicaid, but also taking experience from states like Indiana and elsewhere, in which we attempt to give states the initiative to create specialized programs that focus on patient-centered care. In that way, we will see better outcomes. The current Medicaid funding system under Obamacare works against states, penalizing them for addressing fraud, abuse, and waste. This must change. We need to change this broken framework with a system that will work with states to get their Medicaid programs back on track, benefiting their patients as much as possible. And with that, Madam President, I yield back.